ABC Listen. Podcasts, radio, news, music and more.
Norman, how would you like a full-body MRI?
I'd hate it. The last thing I'd want is somebody looking inside of me to find stuff that was never meant to be seen.
Incidentalomas, that's what you're talking about.
That's right. In other words, you're finding a little lump that means absolutely nothing, but finding it and finding out what's causing it could cause you far more harm than good.
Lots of anxiety as well. But actually, Kim Kardashian suggested to her 300 million followers a couple of years ago that they should all go and get a full-body MRI done.
Just think of the burden on the health system and the lack of lives saved as a result.
And the amount of anxiety for these people. But influencers on social media do spread some health misinformation, and that's something we're going to explore on today's show.
Which is The Health Report. I'm Norman Swan on Gadigal Land.
And I'm Priya Alexander on Wurundjeri Land. Also on the show, what you need to know if you're considering taking a GLP-1 agonist for weight loss, medications like Ozempic or Wegovy. What are some of the benefits and risks to weigh up?
And as promised, how safe is it to replace your table salt with potassium salt? And where in the world can you buy it?
To news now, big promises when it comes to healthcare and bulk billing, Norman.
Yeah, an $8.5 billion promise being matched by the opposition to introduce very significant bulk billing incentives into general practice to increase the bulk billing rate. And the government optimistically is saying that that will increase bulk billing rates to 90%. Well, you're a general practitioner in practice. What do you think, Priya?
I am. So, Norman, I'm going to try and stay very measured here, but my heart did sink when I saw this because I saw the big carnival and the government saying that 9 out of 10 patients would be bulk billed by 2030 under this plan. I think we have to step right back here and try and understand what the promises actually are, because this is not the rebate lifting.
Explain what we're talking about here. So you go and have a 15-minute consultation with your GP. There's a number attached to that, and that's what the receptionist or practice manager will attach to if you were to be paying an out-of-pocket. That's what you'll get back from the government.
Yes.
And what you get back from the government doesn't change there. It's that there's a tripling of an incentive payment on top of that. And so the core rebate to, say, a practice that's not bulk billing doesn't change.
That's right. So let's use you, Norman. You come and see me. We spend 15 minutes together. If I privately bill you, Norman, and I say, even with these changes, Norman, I'm still going to charge you an out-of-pocket cost, the amount the federal government gives you to pass on to me doesn't change. It stays at $42.85. If I bulk bill you, then you get the incentive and the total amount goes up to $63.50 that you'll pass on to me.
So why wouldn't you bulk bill then?
Because it means that a lot of GPs and a lot of clinics are going to have to reduce their income by about 30%.
The incentive doesn't cover the cost of providing care.
It doesn't. To deliver good general practice is expensive, Norman, and everyone knows the cost of living's gone up. To run a clinic, the vaccine fridges, the nursing staff, reception, the printers, the fax machines, all of that has gone up, and $69 is not going to cover the cost to deliver a consult.
So that's a major issue for the government to deal with. But the issue that I'm obsessed with, in addition to what you've just talked about, is the fact that it doesn't fundamentally change how general practice is done. And general practice in general, it's not a fault of individual general practitioners, is failing the healthcare system, or it's not achieving its potential as the more pleasant or positive way to put it, because fee-for-service doesn't cut it. Well, it's fine if you've got a sore throat or an ankle which you think might be broken, in other words, an individual consult. But the real burden on healthcare is people with diabetes, coronary heart disease, multiple diagnoses that need your care, the care of your team, over an extended period of time. And individual payments for individual visits doesn't cut it, because you've got to be able to extend that and be incentivised for ongoing care, and that system doesn't do that.
The biggest incentive here, Norman, is for the shorter consult. So we've said for a very long time as GPs, you're right, people have increasingly complex care needs where you may need more time with patients. Now, the way this
can I just interrupt you there?
Yeah.
You say you need more time with patients. Actually, maybe they don't need any more time with you, but they need more time with a physiotherapist.
Oh my gosh.
More time with a practice nurse.
True. More
time with somebody who's a psychologist who's got more in-depth skills than you do as a generalist, without decrying your skills, because they're important skills. And that's what's needed to be funded, and it's not funded under the current system.
I agree with that, but I also think that there are some patients who do have complex care needs where I do need, for instance, working someone up, a perimenopausal woman, I need at least 30 minutes, Norman. So with these proposed incentive changes, the biggest benefit is still for a shorter consult. So it really rewards fast medicine. There's a smaller percentage increase for the longer consults, which means that, we know from research that women, female GPs, tend to see patients for a longer period of time with often more complex care needs. So it's going to also widen the gender pay gap even more. Now, having said that, there are some benefits to this. I'm not, a total negative Nancy here. For clinics, particularly in regional and rural communities where there's universal bulk billing, this will absolutely make a difference to patients and to clinics where the incentive increases. But I think broadly, this doesn't solve the problem. You're basically asking us to do more. It's like saying to teachers, improve education outcomes but take a pay cut. You're asking us to earn 30% less to try and keep clinic doors open, and you're promising everyone they're going to be bulk billed. And this is already a profession on its knees.
And the major issue here is, do we still have a universal healthcare system in Australia, which we're supposedly very proud of? And if you look at out-of-pocket costs, particularly in specialist areas, and specialist rebates have not changed very much either in this environment, we have significant out-of-pocket costs which disadvantage the poorest most, and we're probably deluding ourselves that we have universal healthcare.
And Norman, I accept that I'm someone who will probably have to pay an out-of-pocket cost to see a GP. Really, the way we need to structure this is to ensure that the people who are socioeconomically disadvantaged, who can't get into the clinic due to the out-of-pocket costs, we need to lift the rebates for those people and ensure that they are able to access healthcare.
So do you know what my solution is?
What is it, Norman? Come and be a GP.
More people should come in GPs, but that's already happening. Kids coming out of medical school are applying for general practice in numbers that they haven't for many, many years, so that's fantastic news. No, my theory is that we should be much more open to different models of care in general practice. So, for example, where you would practice, people overutilise Medicare relative to their level of health. But if you were to, in Melbourne, go out to Dandenong, to the outer suburbs of Melbourne, they underutilise Medicare relative to their standard of health, and in Aboriginal communities as well. Now, what this does is it puts $8.5 billion extra into the Medicare pool. And what that could do is, if they were willing to experiment, is cashing out in some areas what Medicare would spend or should spend on the level of care, and putting out to tender for general practices to have salaried practices and give GPs the salary of staff specialists in hospitals. And I reckon the queue for general practice positions would go up, satisfaction would go up, because you're not on a treadmill of 15-minute consultations.
Well, the treadmill is exhausting, and this is going to make it worse, rewarding fast medicine. General practice consumes 6% of the health budget, but sees 83% of the population. So asking us to be more efficient and to do it for less, it
doesn't work.
Hurts the GP in me, and it doesn't work.
And optimistically, there's an interesting study on how small behaviour change needs to be to get a big benefit.
I love this. This is a prospective cohort analysis, more than 59,000 people from the UK.
Although it's an Australian study.
Yes, and people were wearing devices to measure sleep, physical activity. And really what the study has told us is these are the optimal amounts of sleep, fruit and veggies, physical activity to reduce your risk of dying. But here's also the bare minimum that can yield benefit.
Mind you, it was only 7 days of a tracker. One of the problems I've got with these studies is they make big promises on the basis of small periods of time in a person's life. So a lot of the diet studies is, okay, I'm going to do a self-reported diet diary, even if it's electronic, for a week. I'm going to wear a Fitbit for a week and see what happens to me over the next 8 or 9 years, which is effectively what this study does. And the lead researcher, Emmanuel Samatakis, we've had on the health report before, very eminent researcher, very good. But inevitably, so what happens over that 8 or 9 years compared to that 1 week in time at the beginning of the study? And very few studies follow that up. But let's assume you don't change your behaviour that much during that time. What it really showed was tiny increases.
Tiny.
In the quality of your diet and how much intensive exercise you do. I mean, we're talking about minutes a day, tiny, small amounts of increase in sleep have enormous benefits in terms of reduction of all-cause mortality.
Yeah, so 15 minutes per day increase in sleep. I mean, that's a small thing, and I think people underestimate how big the impact is from the small thing. So I think everyone should go out and sleep a bit more, move the body a bit more, eat more rainbows.
Yeah, just keep that mobile phone upside down with the sound off on your bedside table and don't open it, and that will give you your extra sleep. On Radio National, you're with the Health Report. So I'm fascinated in this next story, Priya, that you've been covering, which is on influencers and medical tests. I mean, this does my head in.
So this is a study which has looked at social media and how it discusses 5 very popular tests which often lack evidence: full body MRI, multi-cancer early detection testing, anti-Malarian hormone or AMH, gut microbiome and testosterone testing in well people. So they've looked at TikTok, Instagram from 2015 to 2024, and they've looked at the tone of the posts, the kind of information in there, and this can be quite harmful. It can really mislead people.
It can generate an enormous amount of business for the healthcare system.
Not easy to navigate this, and I have to say, Norman, that I do have patients who access direct-to-consumer testing, for instance, full-body MRI or gut microbiome testing.
So they're paying for this themselves?
They pay for it for themselves, and it can generate a lot of anxiety. We can pick up a lot of incidentalomas, things that were never going to be harmful. I spoke to Dr. Brooke Nicol, who's a public health researcher at the University of Sydney.
Our study looked at 5 popular but also controversial medical tests, and we specifically found that these medical tests were overwhelmingly promotional and overwhelmingly misleading. And these were medical tests that were being promoted to members of the public, so healthy individuals. 87% of these posts mentioned the benefits of the test, yet only 15% mentioned potential harms. And that's really important because the tests that we chose are all ones that lack evidence of benefit for healthy individuals. So they either have no scientific evidence to back them yet or strong scientific evidence, or we know that they can lead to potential harms such as overdiagnosis.
Often, Brooke, people on social media will share their own personal journey and suggest to followers that this is the way forward for you as well. You should get this test done. How does that impact how people digest the information?
Yeah, I think that's a great question. It is really difficult for people to think about benefits and harms and to think about what potential evidence might be behind the medical interventions that are being discussed when a personal narrative or an anecdote, about a friend or a family member or someone they knew is there. It's really, really hard to think about science when those narratives are so strong and they play on these really strong emotions that we hold in society about really taking control of your own health. Early screening, early detection is better. And I think in many cases, that is a really important message to have. But there are often cases where knowing less information might actually be more beneficial for your overall health.
Did you find a difference between the quality of posts from non-qualified people speaking about these tests versus qualified health professionals?
We did a detailed analysis and found that the posts from medical doctors, posts that mentioned any scientific evidence, and posts from influencers who had no financial interest in the test tended to be more balanced overall. And specifically with the medical doctors, they were definitely better overall, but there were some extreme examples where they were actually some of the worst posts as well. For example, there was a post from a medical doctor who was shirtless in his budgie smugglers, flexing his muscles, telling men that the testosterone test and testosterone supplements will enhance their masculinity and their sexual performance and really give them, a zest or a drive for life. And when these people are legitimate medical professionals, it just really does feel like the wild, wild west in some of the other contexts. But overall, we did find that posts for medical doctors were better in terms of the balance between the benefits and the harms.
So what are the risks, Brooke? What's the potential harm here?
So I guess the harm that we were specifically interested in is overdiagnosis. And also overuse of the health system. So overdiagnosis, simply put, is a diagnosis that can cause more harm than benefit to an individual. Those harms can be physical in terms of treatment harms and side effects, and also psychological. So it's finding things that will actually not lead to any symptoms or problems in a person's lifetime.
And I'm assuming, Brooke, that if people are having some of these tests done, they might actually be falsely reassured and therefore not go and see a qualified health professional for potential symptoms they might have.
Absolutely. I think there's 2 sides to that. So like you said, they can completely be falsely reassured. not actually seek medical interventions when they may indeed need it. But there's a bigger risk of overdiagnosis because typically when people are healthy and they're not displaying any symptoms, they probably don't need to have the test or go seek medical interventions either.
I have to say a bugbear of mine, Brooke, personally, is that, I'm a qualified health professional on social media, and the standards to which I'm upheld with regulations from, for instance, the Royal Australian College of GPs, which are in place for very good reason, but we're held to different standards. And so you're saying the posts often from unqualified people are promotional, there's monetary gain, they often don't discuss the harms. How do we change this to ensure that there's more accurate information out there in the health space?
Yeah, I think the regulations for medical professionals in Australia are really good. And like I said, overall medical professionals were better, but there were still some that were getting through from other countries that were quite extreme. And I guess for influencers on a whole, there just does really need to be stronger regulation put in place for things that lack evidence of benefit and can be harmful when promoted to healthy individuals who may not need it. There's often arguments that individuals, we can boost their health literacy and media literacy and try and make them more skeptical about information that's online. But I do feel that that is a really big ask in a space like social media, where there is so much information floating around all the time in your hand. It's really, really hard for people, even with adequate health literacy, to navigate that information and what might be the benefits and what might be the harms. So I just really, truly believe that there does need to be stronger regulations for these influencers.
And what would that look like though, Brooke? Because I think it's hard for people to actually grasp what potential consequences there might be for individuals who are spreading misinformation either knowingly or unknowingly. What does increased regulation in this space look like?
Yeah, I'm definitely not an expert in the regulation space. We are doing a lot of mapping right now of the regulations that are out there and seeing whether the posts that we looked at actually comply or not with these international regulations and also regulations here in Australia. So I guess it's really that the post would be taken down, it would be blocked in the first place.
And so how do people spot the nonsense? You've just alluded to this, that we can have really good health literacy and still find it difficult.
Yeah, it's a tricky one because, like I said, it's good to look for legitimate medical professionals, absolutely. But there are cases where they are the ones as well spreading some of this information. So that makes it a bit tricky. But I think in the first instance, looking for a qualified medical professional is the way to go. Also, really thinking about the benefits and harms of that test for you. And just broadly, it's important to remember that if information about, medical tests or treatments or any type of intervention promoted by influencers really does sound too good to be true, that it probably is.
That was Dr. Brooke Nicol, Senior Research Fellow for the School of Public Health at the University of Sydney.
On Radio National, you're with the Health Report.
Coming up, the new class of drugs, GLP-1 agonists, are increasingly being prescribed for weight loss. We answer some of those frequently asked questions about them. How do they work? What are the benefits? And do you need to stay on them forever?
We promised last week that we would come back to this story of salt substitutes, potassium substitutes in salt. If you remember rightly, what we spoke about was a Chinese study from the George Institute in Sydney, which looked at recurrent stroke rates and salt substitution, which showed that if you substituted potassium for sodium in a proportionate sense in their salt intake, they got a significant reduction in the risk of a recurrent stroke. So really good results, potentially massive. But we've also had a massive response from the audience, which says, well, what about the risks of potassium substitution and where do we find it in the shops? So to answer some of these questions, as promised, we've got Professor Bruce Neal on, who is the Executive Director of the George Institute. Welcome back to the Health Report, Bruce.
Thanks, Norman.
So let's just summarise the findings now, because these are really quite important in a public health sense.
Yeah, absolutely. What this trial did, or what this analysis did, was looked at people who'd had a prior stroke. They had people who were at high risk of having another stroke. We know already that if you give them drug-based blood pressure lowering, you can reduce that risk. And what we showed very clearly here was that if you gave them a potassium-enriched salt, which lowers blood pressure, and that's almost certainly how it had its benefits, then it also protects against the risk of having another stroke.
Okay, so let's just take a couple of the themes in terms of the response we've had to the health report. One is I'm on a diuretic which spares potassium and it tells me to watch my potassium intake. So in other words, can everyone substitute potassium for sodium, or are there groups of people where they're taking a risk?
Yes, so this is obviously a really important point, because if you have too much potassium in your blood, that causes you problems. And if you have too low potassium in your blood, that also causes your problems. And these problems can be severe, because too high or too low blood potassium levels can cause arrhythmias of the heart, so the heart beats irregularly, and in the worst case, it could lead to death. So if you're already doing something that causes you to have high blood potassium levels, then you would want to think twice about switching to a potassium-enriched salt. And the people who are at risk of having too high blood potassium levels are people who are taking potassium supplements, people who are taking a particular type of diuretic that spares potassium, and also people who've got serious kidney disease, because if you've got serious kidney disease, your kidneys can't maintain blood potassium levels as effectively as they normally would.
And people taking potassium supplements are also people on diuretics to replace the potassium they might lose in their wee.
Absolutely. And look, one of the interesting observations about this debate is that everyone focuses on the high blood potassium levels. Now, we know that actually one of the most common side effects of taking blood pressure lowering drug therapy is to get low blood potassium levels, because most people include a diuretic in that therapy, and mostly that isn't a potassium sparing diuretic. And so one of the areas that we're looking to explore is actually whether co-administration of potassium-enriched salt with a regular blood pressure lowering therapy might actually be an effective way of preventing people from getting low blood potassium.
So let's assume you're in a kind of regular situation and you're interested in lowering your blood pressure by manipulating your salt intake. The common refrain we've had from the audience is, where the hell do you find this stuff?
Yeah, and that is definitely a problem. You can actually get potassium-enriched salts in 50 or more countries around the world, but in no country would potassium-enriched salt constitute more than 1% of sales of salt. And that's because people don't know about it and because it's not on the supermarket shelves. You can get it in Australia, probably only the bigger supermarket shelves, and probably in the health food aisle rather than in the salt aisle. And you can also buy it online by searching for low sodium salt or potassium salt.
And I noticed that in the study, the replacement level was 25% of the content of the salt was potassium. And I think the salt you're talking about in the Australian context is 50%. Is that a problem?
So it's potentially both a problem and an advantage. When you replace the sodium in salt with potassium, the amount of blood pressure lowering you get depends upon how much of the sodium you replace with potassium. So if you replace 25%, you'll get a certain amount of blood pressure lowering. If you replace 50%, you'll probably get almost twice as much. The two challenges there are, first, the safety one that we've talked about. Obviously, if you put more potassium into the salt and you're at risk of getting high blood potassium levels, which is, we should note, only a tiny proportion of the population, then that might be a downside. The other potential downside is that when you put a lot of potassium in, it can get a slightly different flavor. And one of the reasons that we use this 25% potassium, 75% sodium mix in the big study we did was that we knew that actually the flavor was almost indistinguishable to most people.
So what's the strategy somewhere like Australia? I mean, you want to see some degree of implementation of your findings in the Australian context.
Ideally, we'd like to see all salt in processed foods and all salt that you add at home or when cooking switched for potassium-enriched salt. But in the first instance, our strategy is to go for people who are being managed for hypertension and try and get a recommendation into the guidelines which says everyone who's being managed by a clinician for hypertension should switch to potassium-enriched salt unless they've got a good reason not to. And in parallel, we want to get potassium-enriched salt on the supermarket shelves next to regular salt so that those people can find it. And the reason that we've gone with this clinical hypertension management approach in the first instance is that we can deal with that risk side of things. Because if you're seeing a GP or indeed another health professional, they're not going to recommend that you switch to potassium-enriched salt if you're using a potassium-sparing diuretic or if you've got kidney disease. And so that's the sort of compromise position in the meantime.
Bruce, thank you for clearing all that up for us.
It's a pleasure. Thanks, Norman.
Professor Bruce Neal, who's Executive Director of the George Institute for Global Health.
Very interesting, Norman, because I think since we spoke about salt substitutes, a lot of people have been looking for them. I do tell a lot of patients that salt sneaks into your diet in very interesting ways, and it's worth going onto a site like Live Lighter, checking out their food label chart and looking at everything, marinades, sauces, whatever you're cooking with.
And it often accompanies sugar as well. So you
Win-win.
flash the sriracha sauce on your food.
I love sriracha.
So do I. God.
We can be friends.
Let's not go too far. You're on the Health Report here on Radio National.
Lots of people in the media, in the community, Norman, are talking about GLP-1s, medications like Ozempic. We prefer to use the drug name semaglutide, in the context of weight loss, shifting weight to yield health benefits potentially.
When the original use was for diabetes.
That's right. And there's lots of people now looking at them for polycystic ovarian syndrome, reducing chronic disease risk, just trying to move a little bit more. They've been a game changer. There are potential benefits, there are potential risks, and people can have really mixed responses to these medications. And first, we're going to hear from Christine, who had a positive one.
I started the medication to lose weight, mainly because I had had breast cancer. So through lots of contemplation, I ended up using a semaglutide. The benefits of it have been that my food noise has gone. But it's just your whole intake of food is totally different to what it was. And the types of food. I can't eat anything too sugary or too fatty because that just makes me feel ill. So I very much don't overeat anymore. And my body is actually telling me to stop eating, which is, again, another really strange thing for me because I would just eat and eat and eat.
And now there's someone who's had a less favourable experience with these medications. Chloe shares her experience.
So I started on the smaller dose, so 0.25 milligrams, I think it was, and everything was fine. There was a small result with weight loss, so we upped it to the 0.5, and then there was no shift at all in weight for the whole month, which was kind of interesting. So then the step up to the 1 milligram, the first 2 doses of that were fine. I was noticing the side effects starting to really kick in. By the third one, the side effects just went crazy. So ended up in hospital on a drip because I couldn't keep anything down. So I guess there's that disappointment that comes with it. You hear all these amazing things that people drop all this weight and they feel amazing. And to not have that was, a bit disappointing and also a bit concerning. But it is what it is. You've got to give these things a go.
I suppose the good news for somebody like that is that there are new drugs coming on the market all the time, which may work for her rather than the existing ones.
So there are other benefits to these medications, but as you've just heard, there can be side effects and there can be risks. So I've spoken to an expert, Associate Professor Samantha Hocking, who's an endocrinologist at the Royal Prince Alfred Hospital and Associate Professor at the University of Sydney, to ask all the questions that I think people are asking about who should these medications be for how long, and what are the benefits?
So all of these new anti-obesity medications or obesity-modifying medications work by targeting hormones that normally come out from your gut in response to eating food. So we call these incretin hormones because they come from the intestine. And what they're designed to do is tell your brain that you've had a meal. And they also signal to the pancreas that you've had a meal to expect an increase in blood glucose levels, and therefore priming the pancreas to produce insulin to help manage blood glucose. So this is the reason why they were first developed to help people with type 2 diabetes who actually have a blunted incretin hormone response. But because they also signal to these appetite centers in the brain, it was found that they helped people have less appetite, less hunger, less thoughts of food and food seeking. As a result, people ingested fewer calories or less energy, and they achieved weight reduction.
So there's this big study that's come out in Nature Medicine recently with over 2 million veterans in the US showing that these medications can have loads of other health benefits in addition to helping manage diabetes and shifting weight. Can you just talk us through some of the other benefits?
Yes. So these medications are now being studied for a range of health conditions which we know are associated with living with a higher body weight. Things like fatty liver disease, heart failure, obstructive sleep apnea. Now, one of the reasons why we believe that they help with these conditions is that by lowering body weight, you lower body fat content, which we know is really adverse for metabolic health outcomes, so things like fatty liver, type 2 diabetes. It's possible that carrying weight centrally also is a very pro-inflammatory state. And so that's another reason why lowering visceral fat with these agents can help reduce inflammation. So one of the really good things about these medications is they don't just lower weight per se, they also improve really important health outcomes. So they improve blood glucose levels, and we know that having higher glucose and higher insulin levels is a really strong risk factor for cardiovascular disease. And increasingly, these medications are being explored or used in other conditions, including things like neurodegenerative disease, like dementia. There's studies planned to look there. There's even studies that have shown in very small patient numbers, so very early results that we can't have a lot of confidence in yet, but they may improve, say, inflammatory skin conditions like psoriasis, which we know are associated with people with higher body weights and what we call the metabolic syndrome.
You can see why they're called wonder drugs, can't you? Like there's so many other potential benefits, but there are side effects potentially as well. Can you just talk us through what kind of side effects people can expect?
So one of the things that these hormones also do is that they slow down gastric emptying. They actually slow down intestinal motility. So when you take these medications, particularly when you're first exposed to them, that effect of slowing down gut transit, slowing down gastric emptying can be perceived by people as feeling nausea. Now, for some people, the nausea can be quite extreme, and for other people, the nausea can be incredibly mild, and some people are so lucky they don't get nausea at all. Because they affect the gut transit, they can also cause constipation for some people and, oddly, diarrhea for some people. So these gut side effects are the things that tend to limit therapy. So some of the things that we can do is we can dose escalate very slowly, so allowing people a long time to adjust. We can also counsel people about how to eat when they first go on these medications. You're going to get a feeling of very early satiety or early feeling of feeling full. So it's important to eat slowly, to watch out for that signal. As soon as you think you've had enough, don't eat anymore. Because if you do keep eating, it's only going to make that feeling worse. And sometimes that can then result in vomiting. But it's really important to have support from your doctor when you start on these medications. You know, having an appointment early if possible in the first 2 to 4 weeks of being on the medications, just to go back, check in, how you're going, any problems, any troubleshooting that we can do.
Some people might have heard about pancreatitis and suicidal ideation listed as potential side effects, but there's some debate over that. Can you just talk us through where we're at now?
Overwhelmingly, it doesn't appear to be a dramatically increased risk, but I do think there is a risk there. And so I would be really cautious in recommending these medications to someone who had a history of pancreatitis. There may be certain situations where what caused the pancreatitis before has resolved and therefore it may be safe to use these agents. But for people who've had unexplained episodes of pancreatitis in the past, I would still be cautious about using these agents. The important thing is that the risk is very, very low.
Okay.
The other thing to understand is these drugs first were used in people with diabetes. And unfortunately, people who have diabetes have an increased risk for pancreatitis compared to patients without diabetes in the population.
And suicidal ideation?
That's another thing that in weight loss is something we've always been concerned about. And in the past, there was a medication that unfortunately was withdrawn from the market because of an increased risk of suicides. So because of that, the FDA, which is the Drug Administration Authority in America that supervises a lot of these trials, has been very strict with making sure all anti-obesity medications include questions about suicidal thoughts and risk as part of their clinical trial development program. And that's a very important safety focus of these weight loss trials. Now, in the clinical trials where this is being routinely collected on every single participant, we haven't seen a signal. So that's really reassuring because that's been collected in a really systematic way where it's been collected in every person and there hasn't been a signal. Since medications have come to market, maybe there has been some reports where it looks like there may be a higher risk of suicides, and then in other reports, there appears to be no increased risk at all. And so, as you say, this data is conflicting. But obviously, again, prescribing this medication to someone who has a history of depression or a history of previous suicide attempts, it's something where with you and your doctor, you need to discuss it, you need to discuss the potential implications and make sure there's good follow-up and support.
One of the biggest things I get asked in the clinic, Sam, is how long am I going to be on it, Priya? Is it lifelong? Can I use it for 3 months, get a bit of a weight shift? What's your answer to that? How long, if you commence these meds, are you on them for?
So what we know from the clinical trials is that when people go onto these medications and remain on the medications, and in all of these trials, people remain on the high dose of medications, they keep the weight off. And that weight loss tends to reach a plateau and stay pretty level and constant without much weight regain when you remain on the medications. Similarly, they've done clinical trials where people have been on the medication and then they've had the medication completely withdrawn. And those patients off the medication have been followed out to about a year. And we see that in that year, people regain about 2/3 of the weight that they lost. So they're still maintaining some weight loss at 1 year, but the magnitude of the weight loss is quite diminished compared to those who remained on the medication long term. Now, that's really disappointing. But I think there's an actual more important message in that clinical trial data, because not only did they look at weight, but they looked at all these other health benefits that we were talking about before. And unfortunately, when you go off the medication, you also lose those other health benefits.
But cost is a barrier. You're saying ideally stay on the medication for those continued benefits, but they're expensive, Sam. Do we expect that these are going to be more accessible?
The equity issue with access to these medications is a very important problem. When it comes to managing obesity, nothing, unfortunately, really is subsidised through the pharmaceutical benefit scheme or through the medical benefit schedule. So for many patients who are struggling with their weight, it's all private pay and it is very expensive. They range in cost from sort of $285 a month up to $700 a month, which for many people is completely out of their reach.
Huge cost.
Now, one of the things that we don't know, because the clinical trials haven't done this yet, is whether you can be on a particular dose of these medications to achieve weight reduction, but then maybe take a lower dose of medication to maintain weight reduction and all the health benefits from that weight reduction, which would then obviously be at a lower cost, although still a significant cost. So that's something that, in clinical practice, we can explore with patients, that once they reach a weight loss plateau or a weight loss goal, then saying, okay, well, how about we see if by reducing the dose a little bit, you can maintain this weight, and therefore it's a bit lower cost per month for you to remain on the medication. So that's certainly something that people can try with their doctor. There are applications being made to try to get some of these medications, at least for certain subgroups, subsidised through the pharmaceutical benefit scheme. Each application thus far has been rejected, but that doesn't mean we're not going to keep trying. And I think we need that consumer voice speaking to government and really lobbying for increased support and funding so that we can help people. Because as you say, it's really disappointing as a clinician to have these amazing therapies that are available, and yet for the people who need them most, we can't use them because they're out of reach.
It's not just about us writing a script. There's far more to this in terms of lifestyle tweaking, dietitian input, exercise physiology. Can you talk us through what else is involved in managing patients?
As you said, I could write a script, not provide any nutrition counselling, not provide any exercise counselling, not make any referrals, and somebody may lose a little bit of weight, but they're certainly not going to get the same results as we see in the clinical trials, because in the clinical trials, that support is provided as part of the clinical intervention. So absolutely, these medications don't help you lose weight by the medication's action. They help you change your lifestyle and stick to that change to lose weight. So it's actually the changes in your food choice, the changes in your eating behaviour, the changes in your exercise. Now, the medication makes that so much easier than the constant struggle of doing that on your own unhelped, but it's the changes to the lifestyle that actually result in the benefits.
That was Associate Professor Samantha Hocking, endocrinologist at the Royal Prince Alfred Hospital and Associate Professor at the University of Sydney.
And as we discussing this in the studio, there's been a study out in the British Medical Journal about deaths associated with adverse reactions to these drugs. And I mean, somebody said to me the other day, if you've got a drug with no side effects, you've got a drug with no effects. So it's not as if there are no side effects here, and we've heard some of the negative stories here. This study on deaths, we'd have to say, though, is problematic. It's very hard to ascribe cause and effect. It's an association. And you have to remember also that people who are on these drugs often have other problems as well.
100% agree. And also that any time we use these medications, be it for diabetes or be it for shifting weight, it's always nuanced, it's individualised. There's so much to consider. And we're actually going to deep dive, Norman, further later into GLP-1s and eating disorders and the potential implications there.
And if you want to report a side effect of a drug, you go into the Therapeutic Goods Administration website. There's a reporting mechanism there.
On Radio National, you're with the Health Report.
Time for mailbag, and a lot of response to your story last week on breast density.
Yes, so Jackie's written in saying that she was lucky to have her breast cancer found by a routine mammogram and confirmed after further screening from Breast Screen Victoria. She did have very high breast density, but it was detected, and her surgeon actually told her that she'd need annual MRIs ongoing. But she has pointed out that it can be quite costly to have ongoing testing. And I, in fact, called a radiology department to confirm that even with a referral from a breast specialist, the out-of-pocket cost for an MRI is between $315 to $700.
Gosh.
It's a lot.
So this is interesting because they're rebating on MRIs of the prostate.
There is a rebate, so you could potentially be $315 out of pocket if you get the maximum rebate, depending on what clinical information's on your referral. But I did confirm with the radiology place that I called that there is a significant out-of-pocket cost for most.
Which just adds to the problem of women with breast cancer, and people with other cancers, but it's been best documented with breast cancer, is in the course of years with your breast cancer, if it's not curable, you can live for 20 years for many, many years with it as a chronic disease. You could be $40,000 out of pocket. I mean, thousands of dollars.
But we were talking in the context of high breast density. So if you're someone without breast cancer, high breast density, and you need supplemental imaging, it can be quite costly to further assess your risk if you need more investigation.
Yeah. You think it's in the interest of the system to not have cost as a barrier. Otherwise, you've got the personal cost of having breast cancer missed and the cost to the healthcare system.
Jasmine's written in saying that wondering why breastfeeding wasn't mentioned as a lifestyle factor that reduces the risk of breast cancer. Fair point, and there is strong evidence that breastfeeding protects against breast cancer. That's actually directly taken from the Cancer Council. It is a protective factor.
I mean, it's interesting, the reason why it's thought that breastfeeding protects against breast cancer, it's that you have fewer periods, you have fewer menstrual cycles if you are breastfeeding. And one of the things that drives breast cancer risk is the number of menstrual cycles in your life. So if you've got early onset of periods, or you have late menopause, you are at increased risk because your breasts are being driven each month. So giving it a rest with breastfeeding, if you're able to breastfeed, is a good thing.
And of course, not everybody can. There's lots of reasons why people can't breastfeed, but yes, it is a protective factor. Marge has written in saying that she asked about breast density at the Maroondah Hospital Breast Screening Centre, and they said that they have the software, but they're still not providing the information to patients or GPs. And it's just worth remembering from the chat last week that in Victoria, it's a pilot and it's slowly being rolled out. So some people will get the information, some people won't, but eventually it should be rolled out across the state.
Just remind us then, Priya, from last week's interview, let's say you do get a report of breast density, what does a woman do?
Bring the result and come and chat to your GP, and I'm probably going to use stuff that I've learned through this process. I prevent looking at risk factors, seeing whether or not you need supplemental imaging, or if we can just work on the risk factors and reassess.
Does the average GP have that information?
They do. I would go to breastscreen.org.au. It's all there. If you want to write into us, please do at healthreport@abc.net.au.
And don't forget our companion podcast, What's That Rash, where this week we deal with muscle cramps and what can we use to treat it.
Are we sculling pickle juice, Norman?
I'm not sculling pickle juice just yet, but I have to say I had a run of really bad muscle cramps when I was overseas recently. And I ended up going into the local chemist in Austria and buying magnesium and trying that. And interestingly, in Austria, it's probably easier to get pure magnesium than it is in an Australian pharmacy where it's often alongside B vitamins.
There you go. Well, all the tennis players are doing it, so I might give it a whirl.
The pickle juice, yep.
Yep. In the meantime, Norman, see you next week.
See you then.
You've been listening to an ABC podcast. Discover more great ABC podcasts, live radio, and exclusives on the ABC Listen app.